Very good. What do you want to do? Is wait for Jeff in Dallas?
Let's go ahead and start talking, and then Jeff can come join us. We will record this, and we can actually give it to Jeff to access by Vimeo. And so we've got it. Everything's being recorded, and we're posting everything,
including the pictures.
Including the pictures.
Very good, because Jeff was particularly involved with this discussion in the past, and it would be good for him to see the pictures too.
Yeah, I will text him and see if he's coming. So hang on for a minute.
All right, so we can start whenever you want to transfer the organizing or presenting role.
We will transfer right now.
All right.
And so, Paulo, I believe you're the presenter now. I see giraffes on the Serengeti.
Wonderful. Were you there?
I haven't been there yet.
You're not the one on the left? It looks like your neck.
I stick my neck out frequently.
Are you going to be in town soon?
No plans right now, but I'll be in touch with you when I'm coming that way. Love to see you again.
Very good. So today we're going to start with a subject that is very interesting in whoever wants to understand what is Takotsubo, because it completes and goes a little bit in more depth the description of the spectrum that we need to imply when we come with a general theory about how Takotsubo comes about. This is the sub-type of Takotsubo in which not all of the apex only is involved, but more of the proximal part where the apex is preserved. Let's see if we can give you a background introduction. There are two interesting previous discussions of this subject. One is ours in a letter to the Mayo Clinic Proceedings in 2009 that they considered privately very interesting and stimulating, but not adequate for a main presentation because it was a case report only. But it was a case where we presented the mid-ventricular variant of transient apical ballooning, where we did an acetylcholine test to show why these patients could be presenting as such in place of the apical typical distal ventricular balloon. In the case, it came out that there was a good input in understanding the pathology because the acetylcholine showed severe spasm everywhere, but in the LAD was only moderate. So there was no subtotal occlusion by diffuse narrowing of the LAD, while the others were all involved in severe diffuse spasm. That case reproduced the echo-proven relapse of Takotsubo during the acetylcholine that disappeared quickly with nitroglycerin. So it was a good idea, an interesting finding, but obviously one case. Today's case is very similar to this in the presentation. I want to show you the second of the series. Obviously, we need many more to understand it in all its complexity. The second paper is a paper we're discussing with Eduardo Hernandez recently. He's involved in our study on coronary misbehavior in Takotsubo. And it's a paper written by the people at the Mayo Clinic. It's published in European Heart Journal 2013, where they considered the impairment of coronary microvasculature as shown by adenosine and acetylcholine testing. This was out of a population of 250 cases. They studied 10 patients at an average mean interval of 5 months after presentation. So in unlikely illuminating evidence on the subject, because we think that there is something transient that doesn't last more than a few weeks. But at 5 months, they claim to have discovered impaired coronary microvascularity reactivity in women that had suffered from ballooning. In particular, they come up with this finding of the median change in diameter was 13% decrease in acetylcholine testing, and flow reserve was only 2.2 in place of 2.5 or higher in normal. So very light, or I don't know how objective in 10 cases can be. But that's their conclusion, that this indicates that there is a long-term endothelial dysfunction, and they don't come into details how eventually one episode occurs. Our idea was to try in acute stage to see who is likely to recur and what is the mechanism. So next is another interesting recent input on the subject. And this is a case being published right now, where a patient with a typical Takotsubo presentation comes with an unusual, but in the sense that it's rarely reported, but in my experience, it's probably 15–20% of the cases that have an acute ileus or paralysis of the intestine as the initial symptom of a Takotsubo episode. This 77-year-old goes to the hospital after 6 hours of chest pain, abdominal pain, is worked up for this in the ICU. CAT scan proves that there is ileus, with typical findings on CAT scan. After 2 days, she manifested with a full syndrome of Takotsubo, with chest pain, hypotension, pulmonary edema, and they do only 3 days after admission a heart catheterization that shows in the first of 3 pictures that I'm going to show in this case is significant but not total occlusion of the LAD that is dominant. In another projection, it looks more complicated, definitely suggests that it is a clot-complicated region, but with prograde flow and minimal ST depression. In diastole, this is the picture, and systole, this other is the picture. Apical ballooning is pretty acceptable, even though it's not totally typical. Usually it is typical to have a more rounded akinetic. This comes up where the LAD doesn't go, in the mid-inferior wall, and to complete the description of the case, the patient has an LAD angioplasty with a diagnosis of 90% stenosis by this colleague who is outside our hospital. And eventually she does very well, and I see the patients 4 weeks after the episode that the ventricle is totally normal. The MRI for scar is totally negative, and it seems like it was a definite Takotsubo. That talks about what is coronary disease in Takotsubo. Is it an exclusion or just a convenient exclusion that we put because we don't know we want to be sure that this normal coronary artery, quote unquote, akinesia or dyskinesia section of the heart. The fact is that this patient had on top of the coronary disease, atherosclerotic, an apical dysfunction that is transient after a late presentation since the beginning of the pattern, has a minimal elevation of troponin that doesn't explain, that doesn't go with this extensive hypokinesia of the apex, and recovers in less than a month. So it is this case was asked to be published when I function as an editorial consultant for a journal that wants to publish this too, in connection with another case of the same type, ileus complicated with Takotsubo, and this will become available in the literature soon. But the case we want to expand on this time is this mid-ventricular Takotsubo of a 60-year-old female with the predisposing factor for Takotsubo, consisting of a recent death of an estranged father, a big emotional problem for the lady, a recent onset hypothyroidism that was started with what resulted to be excessive compensatory treatment with Synthroid. She was TSH of 0.1, so probably hyperthyroid after being hypothyroid, and comes to the hospital after being woken up by severe chest pain with sweating, but also actually initially abdominal pain, and now nausea and diarrhea. Goes to the bathroom and comes back to the bed, and she started having chest pain. So at 5 hours, the chest pain became intolerable with weakness, dizziness, shortness of breath, and she decides to go to the hospital. At that time, she is treated with morphine, and the abdominal pain is immediately relieved, and the chest pain improves. But the ST remains abnormal with ST elevation. Eventually, this progresses in prolonged ST and negative T waves in the anterolateral, and that resolves eventually in a few days. Again, the troponin in this patient is only at the peak 3 days after, 2 days after start of the symptoms. 5.9 nanogram. Echo shows apical akinesia at 20 hours, but the interpreter of the echocardiogram did not comment on the reason or if it was or not Takotsubo, and they called the apical portion of the left ventricle to be akinetic by echocardiogram. This variant of Takotsubo is confused with the regular Takotsubo of apical ballooning. So she comes to the cath lab. Yes.
We have a question from Jonathan. He came back and he has a question for you about the first case.
All right.
John, do you have a question for Paulo? John, everybody has to mute for John. Everyone has to mute for John because we're getting feedback if we don't. John is feeding back on himself. John, would you like to talk?
Yes, but the echo was terrible, so I was trying to...
Yeah, I tried to mute to get rid of the echo, so I muted everybody except you.
Okay. There's still kind of an echo. Anyway, Paulo, the question is, on that first case,
Okay, he's on twice.
try not to, I'm going to put my fingers in my ear so I can't hear the echo.
I think you're on twice, John, so you're echoing yourself.
I don't know where am I twice. I thought you said you were on
Paulo, we've got you back up again.
He's not going to talk until the
Well, he was logged in twice, and so he was ricocheting off of his own mic.
What should we do?
Let's go on, and we'll ask questions at the end.
Okay. So at the cath, 22 hours after admission, we will show the pictures of both of the coronaries and the left ventricle. So this is the first of two angiograms of the coronaries and the left ventricle. We don't show the echocardiogram. It was not very good in quality, but we will see much better the ventricle in the left ventricular angiogram, and the diagnosis can only be made by this study. You see there is slow flow in the LAD with an impression of a mild stiffness, but is more the wall than the stenosis of the coronary artery. Basically is a little spasm. We don't know how much, if not after given nitroglycerin. Next. You see how slow is the LAD filling? It takes much longer than the circumflux. Next. The obtuse marginal 1 or larger amos is also slow. Next. 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 Definitely no atherosclerotic changes. There's a little coronary anomaly that consists of a split right coronary artery, but it's a dominant or codominant pattern. Next. Next. This is the important picture. You see by angiogram very clearly that the apex is contracting. At least 10% of the longitudinal diameter of this ventricle is still preserving its contractility. The mid portion of the left ventricle, something like 70% of the left ventricular longitudinal diameter, has akinetic segments, very typically symmetrical around the longitudinal axis. Is not the territory of a single artery for sure. It's both territory of the obtuse margin and the right, as well as of the upper portion, at least, of the LAD. But the apex continues to move. Next. We go to the. So this is 3 days after, when the left ventricle has improved, and the doctor that admitted the patient was thinking of sending the patients home. We had the idea of testing with acetylcholine the possibility that there was a spastic interpretation of the case with acetylcholine and nitroglycerin administration. This is the baseline when it had improved the left ventricular function, but it was still hypokinetic, severely hypokinetic in the distal left ventricle. Next. This next picture shows the 100 micrograms of acetylcholine response. It looks like there is a slow runoff, in part because of bradycardia, but especially in the midsection of the LAD. I think that there are two pictures in slightly different projections, where both the left ventricular function get worse, and there is more clearly mid-LAD diffuse stenosis. Next. This is with an echocardiogram, while we're doing echocardiogram. Next. Just past it. Okay. So this becomes pretty much 80–90% diffuse. But this is the worst we show it in this acetylcholine test. And the next. Next. So after nitroglycerin intercoronary, everything becomes pretty normal, puffy and smooth, and no stenosis. Everything, including the obtuse margin of 1 that was so dominant, is now healthy looking with a good runoff. Evidently, there's a combination, in this case even only angiographically, of having both epicardial vessel stenosis and microcirculation diffuse narrowing with increased resistance and slow runoff. Next. This looks very healthy, LAD and circumflex system. Next. As there was obviously important inferior wall hypokinesia, and you will see some evidence of apical hypokinesia of the right ventricle. You see here by echo, it looked very suspicious of apical right ventricular hypokinesia, or it was not ballooning, but definitely hypokinesia of the apex of the right ventricle. We want to see this both at baseline and after acetylcholine. Next. It's a little worse with acetylcholine 50. Not clearly abnormal, but it started abnormal. Next. The right coronary artery. Next. With acetylcholine is pretty much normal. At this time, there is not much response of narrowing. Next. Maybe here the distal segments of the posterolateral branch and also the posterior second branch of the right coronary artery, the anterior bifurcation, are narrow, but she did not feel any chest pain at any time. Next. And this is after nitroglycerin. They can show the difference. Obviously, there was some diffuse acetylcholine caused narrowing that is resolved with nitroglycerin. Now it's a very healthy split right coronary artery. The next. And it looks like this right ventricular function has improved. Next. Do you think you can see the echo in the beginning? Yeah, let's see if we can see more chambers of the left ventricle to show how difficult it is by echo to see apical preservation of function in the otherwise typical Takotsubo. You see at the apex you don't see very well the preserved function. It looks like diffusely akinetic, but it was a little worse with acetylcholine. We go down to the next question, the left ventricle. Here we put some bubbles to see if we could see better the apical dysfunction of the right ventricle. And you can see it a little better, but it's not a very good window. Next. This is again with bubbles. The apex doesn't move as well as after nitroglycerin. Next. The inflow of the left ventricle is pretty preserved. Next. Function. I think you see at this time the left ventricle is diffusely dilated. This is under acetylcholine effect. This is much larger diameter in system. Next. All right. Next. Let's go to the presentation of the PowerPoint. Next. So the ejection fraction at this time was 35%, similar to what it was at presentation. The acetylcholine test is fairly typical of the typical case of Takotsubo, but is not repeating the pattern of spasticity that we had in the first case, where the stenosis, the diffuse stenosis, was more diffuse and the LAD was not better. In our case, in this case, the LAD was worse than the rest of the main vessels. Nitroglycerin definitely corrected both the baseline and the after acetylcholine narrowly. Next. So it's definitely endothelial dysfunction, and we didn't do the acetylcholine is done, but there's a question if we need to do also routinely adenosine testing to see, to quantitate how much is endothelial dysfunction at the epicardial vessels and how much in the arterial level. Next. So I can come up with some sort of discussion of what is Takotsubo in terms of the necessary minimal requirement for inclusion and the exclusion criteria. This is compared with what the Mayo Clinic upgraded their discussion on the inclusion-exclusion criteria in 2008 in American Heart Journal. Segmental reversible hypo or dyskinesia is an important baseline in the absence, obviously, of intervening bypass or PCI. It would be important to exclude that there was a problem at the apex before, but especially that the ventricle recovers within a month. So severe dysfunction with mild troponin elevation and total recovery or substantial total recovery within a month. The most important inclusion criteria in our experience recently is the reproduction of Takotsubo by an acetylcholine testing. But the more cases we do, the least solid is the finding of having consistent spasticity of severe degree. Basically, like in this case, at 3 days there is still baseline hypokinesia, and acetylcholine cannot really document recurrence. And these patients had very low symptoms or no symptoms with acetylcholine, even in the presence of significant stenosis. we do not believe, and now more than ever in the past, that coronary artery disease fixed atherosclerotic is an exclusion criteria. We saw now both published and unpublished cases where there was a total occlusion of the LAD with a preserved left ventricular function due to a progressive development of the stenosis in the presence of adequate collateralization, and still Takotsubo reversible apical dyskinesia can occur in these patients. So the second exclusion criteria that is mentioned also in the last Mayo Clinic statement, the pheochromocytoma is an exclusion because it can cause by catecholamine hyperproduction the pattern. Why would you exclude just because we would know what the cause or the precipitating cause would be? It's not clear why it should be an exclusion criteria. And also, the same discussion is about intracranial bleeding or trauma. In the hands of neurologists, their experience in this context of intracranial bleeding and trauma is that they have a typical Takotsubo presentation. So the T changes seen in this context are now routinely assigned to spasm of the coronary arteries, and basically the literature on EKG changes during intracranial bleeding or after surgery or after trauma are considered to be manifestation in the group of Takotsubo. So I would consider that excluding. It's just a different precipitating cause, and it could be also a predisposing cause that's probably baseline endothelial dysfunction. Myocarditis too. If we have a myocarditis documented by biopsy, still they can have Takotsubo, and the difference can only be established with an acetylcholine testing. But it could be that the patient with an acute myocarditis can have an episode of Takotsubo. The fact that it's a manifestation consisting in a territorial, segmental hypokinesia, but in so many different manifestations, even localized. The one that's called local or lateral hypokinesia of Takotsubo has only a territory that would be in the obtuse marginal. It is assumed, but the experience is so little, assumed that this Takotsubo is reversible, accompanied by a patent artery feeding that area and resolving in a few weeks. So it should be compatible, but in those cases we need to have an objective testing like acetylcholine that can reproduce the original presentation, clinical presentation, to be more sure. The absence of mental stress definitely is not in favor of not being in Takotsubo. Mental stress is probably only 50% of the cases, and catecholamines elevation is not the criteria that should be considered to be a requirement to make a diagnosis. Catecholamine elevation is probably present in 10% of the cases. Next. So what is that? This is a comment to the first case of the ulcerated LAD lesion. What is the reason why an ulcerated lesion that is non-obstructive, not causing by itself apical dyskinesia of the amount that we saw in that case, why should an ulcerated lesion be considered an exclusion criteria? The reason to put that criteria was most likely at the beginning corrected because we didn't know exactly extent of the spectrum of this pathology, but now we know. And if there is no total occlusion by ulcerative plaque, there is no mechanism of causing apical dyskinesia of this amount, and it shouldn't be by itself an exclusion criteria. Especially the fact that everything resolves without a scar. MRI is a perfect technology to show that there is no scar at distance. It's excellent support to the idea that you can have even a partially occluded and ulcerated lesion, but not apical Takotsubo cannot be excluded. And is this the last one? Yeah, this is the last one that we can discuss both with John and Eric and Dr. Morales, what I said and what I didn't say, and see if we can agree with some of the conclusion that I will propose. Obviously, it will require more cases to understand the spectrum, but there is evidently a history in the episode of Takotsubo in any single case that is pretty much unknown in its full extent. The appearance and disappearance and the fact that these patients seem to be vaccinated from a repeating episode of Takotsubo is fascinating and difficult to explain. We don't know why all of a sudden a patient comes with such a dramatic dysfunction of the left ventricle that it remains. It would be an indication for transplant. And then it disappears by itself in a few days, and they never had any other recurrent episodes. That's totally unknown in the previous experience in coronary disease. Are we still activated for John? I think his cases were similar to...
Yeah. All right, Carlos, can you hear me?
Still with an echo.
John, you still have an echo. I think that you have you logged in twice there.
Yeah, but one's on mute. I can here. I'll shut this off.
Now it's better.
Go ahead, John.
All right, so Paolo, I'm trying to follow the arguments that you're making, so let me see if I can summarize this. You're saying that there's a spectrum of Takotsubo and that some of the times you see lesions that look like atherosclerotic disease, but if you but they have other characteristics like global hypokinesis, not a very high elevation in troponin, and the LV function improves over time. Is that basically the argument like in the first case? You don't think that was
the first, but not the second.
You think it was spasm and then thrombus at the mid-LAD?
Yeah, that was the argument originated by the first case.
Mm-hmm. And do you have any intravascular ultrasound data on those kinds of cases to see whether there's atherosclerosis or thrombus?
I don't think that would be with any probability of truth a case of spasm causing that appearance in the proximal LAD. That was, if you see it in angiography, we can present it another time. I have only these two pictures here, but those pictures are typical of not spasm, but a non-obstructive lesion, eccentric, with the superimposed non-obstructive clot. In different projections, you see more or less stenosis, but surely a very localized, but not smooth margins. Narrowing, it would not disappear until they put the stent and the best vasodilator.
Yeah, it would be more convincing, I think, with intravascular ultrasound or even near-infrared spectroscopy to see if there's any lipid, whether there's a plaque underneath that. So maybe that's something that could be done in the future cases like that.
This patient, the first patient was done in another hospital, and I saw the patient only after several weeks when she had recovered and needed to have surgery. But she did not accept to do this.
So, Paolo and Eric, we have two cases that we'd like to present to you. Is that okay?
Paulo, were you there?
Yes, for me it's perfect.
John wants to present two cases.
You given the controls?
I'll give it to you right now.
Good. Okay, so my fellow Kuya Bakuwer is going to present these two cases. Kuya?
Thank you. Let me know if you have trouble hearing me. I'll try to go through these be concise. So case number one, these were both recent in the past several weeks. She was an 87-year-old female, history of hypertension, Alzheimer's, and COPD who was brought in by AMS for concern of STEMI. She was living in an assisted living facility, was found to suddenly be hypoxic, unresponsive to albuterol, and she was desatting to the 50s and 60s. EKG and fluid was concerning for STEMI. Initially, she was a poor historian. However, she did endorse chest pain, which for patients started at 3 p.m. with dizziness. Arrival to our ED was about an hour and 45 minutes later. Past medical history is up there. As far as the medication, she was on products for history of stroke and albuterol. When she initially presented, she was hemodynamically stable, but in respiratory distress on face mask. Her JVP was elevated at about 10 centimeters of water. Labs were pending on presentation, came back shortly after, which you see on your screen with the troponin at that time of 0.08. This was her strip initially by EMS, which you could appreciate some key waves in the anterior septal leads with some ST elevations as well as ST elevations in the lateral leads. This is an EKG upon presentation with a nonspecific interventricular conduction delay as well. I'll quickly she was taken to the cath lab for a STEMI, and I will show you our images. So here you could appreciate that there is slow flow but no clear obstruction in the circ or LAD. Again, here's our areocranial, shows the LAD is patent. This is another shot, again demonstrating the slow flow. You see this area here, which initially we were a little bit concerned if there was something there, but it was just some contrast given the slow flow, which we demonstrated on IVUS and OCT. And then here is our RCA, which is a moderate lesion in the mid segment. And then our LV-gram, as you can see, hyperdynamic base with really mid-ventricular to apical akinesis, but interestingly, the apex does come in a little bit here as well.
So this is more mid-ventricular, right, Paolo?
And then this is
the EKG was
this
not
is after
typical.
So, and then this is after 25 of acetylcholine, which you could see severe vasospasm of the LAD with no flow. And then after our first nitro, which is given immediately, again, the LAD starts to open up, you have slow flow, and after the third round of nitro, again, you have restoration of flow in the LAD.
Better flow than even at baseline.
And then I will show you guys some. So we talked about our coronary images, obviously she's volume overloaded, and here's our echo, which demonstrates, again, basically the anterior 2/3 or so of your ventricle not really functioning. Your inferior wall is coming in. Show you guys a few other images as well. Here is the portion where we saw in the LV-gram as well, where the apex does seem to have some contractile function. Yeah. So this was basically her echo initially with an EF of 20 to 25%. A week later, her LV function had already improved to 35 to 40%. Overall, she improved. She was found to have pneumonia and UTI as well. She did develop AFib and ultimately was not able to tolerate any beta blockers, which she went into significant heart block. But overall, her LV function improved. She was walking around the hospital. She was discharged 10 days later.
So, Paolo or Eric, any comments about that?
Paolo, would you like to discuss this?
Yeah, it would be interesting to review the EKG. The EKG seems to show more or less the elevation in the lateral lead, high lateral, than at the apex. Not that it is solving the discussion of what it was, but definitely it was not typical. It is more supportive of a diagnosis of mid-ventricular. You see lead 1 and AVL have a ST elevation, but the rest of the leads and precordial leads don't have it much. Maybe V1, V2 have more ST QS. Huh? The EKG evolved into a normal EKG or just remained with the anteroseptal infarction pattern?
Oh, later on she ended up having the non-specific interventricular delay, but the Q waves did resolve actually. I don't have it to show you.
Did she actually develop R waves? Recording?
Yeah, they were not as significant. Yeah, she didn't have Q waves. And she
Paolo?
At the time of this, yes.
Any more comments?
The apical occlusion resolved gradually or suddenly. It was not definitely a sort of a bubble or some sort of an event occurring during the injection, because it looks like there is a sudden narrowing to total occlusion more than diffuse narrowing like you were expecting spasm in Takotsubo. It looks like a large artery all of a sudden comes to a total occlusion. And was there any chest pain at that point?
Yeah, she did develop chest pain at that point.
This is a different patient that's on the angiogram. We're trying to get the previous patient's angiogram back up. There it is. No, but that's the one post nitro. Yeah, that's the response to the acetylcholine. So you're concerned about the fact that it seems to stop, but I don't think it's an acute occlusion. I just think it's diffuse distal spasm and no flow.
Unmuted.
And then all of a sudden it's like a clot embolization or an air embolization that stops completely all of a sudden the flow. So she had severe pain at that time and gradually resolved. Was there any time where you saw diffuse stenosis?
She did develop transient pain, and she had transient ST elevations on the monitor with that vasospasm.
With the acetylcholine.
With the acetylcholine.
Unmuted.
At the end of nitroglycerin full effect, there was no appearance of a vessel in the high lateral region because there was an area between the LAD and obtuse margin that seemed to be free of vessels, like there was a total occlusion of the high lateral portion where the ST elevation was at the beginning at baseline.
That's the areocaudal view. I don't see any area that's not being, that there's a missing blood vessel.
In relation to the presentation. Are you sure?
No, 2 hours.
What was so the timing of from presentation to acetylcholine challenge was what?
Time?
Time was from ER to acetylcholine challenge was probably 45 minutes or so.
We tend to be studying patients a few days after presentation, and it may be that in the most intense episode, during the most intense part of the presentation, if you give acetylcholine, you'll have a subtotal occlusion of the artery instead of a more diffuse type of narrowing, yeah.
Okay. Should we show you the second case? We have some questions about that one.
Let's go ahead. Take a look at that.
Guy.
Yeah, so this is going to be a 30-year-old guy with no past medical history who was brought in by EMS after cardiac arrest in the field. He was reportedly healthy and active at baseline, training to become a kickboxer, so very active. Family was, per family, patient was complaining of chest pain the day prior, and on the day of presentation was found to have difficulty breathing by his mother. He had no other symptoms. He was suddenly found down by his mother. CPR was initiated by her for about 5 minutes prior to EMS arrival. EMS found the patient with agonal respirations and V-fib arrest. He was shocked. 2 times epi was given with the return of spontaneous circulation. He was ordered to have bitten his tongue with some incontinence. There was no history of illicit drug use, no fevers. He was intubated and unresponsive. He was brought to the ER. Head CT was done with no acute findings. Urine tox was unrevealing. So the past medical history, as we described, he was really on no medications at home, healthy 30-year-old individual. He came in intubated on 100%, of IO2 of 40%. Heart exam at that time was regular. Labs initially were pending. Shortly after, they're on the screen with a troponin of 0.06, which later peaked at 12. BNP initially was less than 20. Strip on the field, concerning for ventricular tachycardia. He does have an underlying left bundle which we developed. When he came to the ER, again, this was his underlying left bundle. Let me show you guys quickly his angiogram. Sorry, one. So here we go. I apologize for that. So this is our arteriocaudal. So CERC and LADs appear patent, no significant obstructive disease. Again, in our cranial view, nothing in the LAD. I'm just going to go through the images.
So no obvious spasm either.
RCA, again, patent. So this is with initial acetylcholine. This is 25. And then if you could just pay attention to the mid to distal LAD segment, and then at 100, which there appears to be some vasospasm in this area compared to his baseline caliber.
The whole artery is sort of diffusely narrowed.
This is his LV-gram, which just demonstrated global hypokinesis.
Was the LV-gram done before the acetylcholine?
The LV-gram was done before the acetylcholine. Sorry, these are out of order. Again, global hypokinesis from the LV-gram. So quickly, yeah, so he was, sorry, let me just show you guys some of the initial echo images. So you have the global hypokinesis. Here he had some moderate to severe mitral regurgitation. The inferior wall appears to be coming in more than the other regions. Apex here again has some functionality. This is demonstrating the mitral regurgitation. So EF was ultimately read as about 20% with severe global hypokinesis, and there was moderate mitral valve regurgitation. Hospital course was successfully weaned off of pressors. After rewarming, he regained neurological function. He really didn't have significant deficits. Ultimately underwent ICD implantation for secondary prevention. On further workup, he underwent a PET scan for sarcoid, which is not significant. A cardiac MRI looking for trying to rule out delayed enhancement, any suggestion of myocarditis or left ventricular dysplasia was also negative. This is these images are 5 days after his initial presentation, which, as you can see, has robust return of his LV function. His MR is significantly better now, traced to mild. And this is, again, his septum is abnormal, but he has an underlying left bundle branch block. And you can see that he has regained a significant LV function 5 days afterwards. So his follow-up echo was read at 55%. The paradoxical septal motion from the left bundle. He underwent the ICD and ultimately received another echo, which is 10 days after, which demonstrated even more significant return of his LV function to 55 to 60% and improvement of his mitral regurgitation to only trace MR.
That's it. So, Paolo, I wasn't sure if this was Takotsubo or not, because it really didn't have the basal hyperkinesis and sort of apical ballooning. This was more a global hypokinesis. The troponin went up to 12, not a huge amount. But I wasn't sure if this is myocarditis or something else. What do you think?
Paulo, what are your thoughts? Hello, Paulo.
Understand correct? Yes, the history says that he was involved in kick boxing, or it was a previous activity in kickboxing, because this could be a traumatic episode of trauma to the front of the chest involved in the heart and causing the atrial fibrillation, and eventually this would be just a result of the cardiac arrest that both explains the diffuse hypokinesia, stunning of the myocardium, and the EKG changes. But I don't understand well the history.
Can you hear me, Art? So he was not doing kickboxing when he had his cardiac arrest. He was at home with his mother and just becoming more progressively short of breath and then unresponsive. So this, we thought about was this trauma to the heart and defib, but that was not what happened.
Did he? I guess I was a little confused. Did he have a cardiac MRI?
Yes, it did. It didn't have any significant findings, no signs of delayed enhancement, nothing really that was significant on the MRI.
And how long were his symptoms occurring at the time he went into VFib arrest?
This was from his mother. He had, he was short of breath that morning, which became progressive, and then he had sudden acute shortness of breath and ultimately arrested.
So typical findings for myocarditis typically occur usually around 2 weeks after symptoms start. So if you do an MRI at the time or around that event and there's a high suspicion, you should repeat one 2 weeks following.
We really couldn't, as much as we tried to get much from history, that really made us concerned for myocarditis. He had no constitutional symptoms, no fevers, no URI symptoms. In general, this seemed to be a more acute presentation.
Paulo, any comments?
Now, in favor of not myocarditis but sudden cardiac arrest is the fact that he recovered to normality in left ventricular function or almost pretty quickly. Myocarditis will last a little longer. But it's difficult to be totally sure. The left bundle disappeared in how long?
Interestingly, the left bundle did ultimately disappear. He developed more of a typical right bundle pattern.
I see that now you're doing all the cases routinely in the acute phase of an early direct admit to the cath lab type of acute syndrome.
Found from a practical point of view, Paulo, we can't get the patients to come back several days or a week later for a second heart cath. So we decided to just start using the acetylcholine acutely. The degree of spasm that this person had with the acetylcholine, what do you think about that? I mean, it's not a normal response to acetylcholine.
It is not the normal. The usual acetylcholine-induced spasm is diffuse and usually total, but it can be total. But we don't have so much experience in patients treated with or studied with acetylcholine in the very early stage of presentation. It could be that the response is more dramatic and more sudden occlusion like than diffuse spasm, which may be more typical of the recovering phase of the Takotsubo. But it's surely important to do these studies because the evolution is very important to understand.
So, Paulo, the other question I had is, do you have experience, or I guess you said you just said you didn't have experience, but for someone who has a cardiac arrest, what happens to their endothelial function? Do you get acute abnormalities of endothelial function, and so the acetylcholine may be positive just because this person arrested, as distinguished from most other Takotsubo patients who don't have a cardiac arrest when they come in?
It is likely that you're right, that the arrest in itself causes endothelial dysfunction as a stunning of the myocardium. The difference is more probably discoverable a little later because there is so much going on at the beginning metabolically and low cardiac output related more than spastic, but it is something that is interesting to see. The spectrum can be understood better if somebody does different protocols at this stage, more than a constant definite time. At 1 week, if you do the acetylcholine test after 1 week, having the left ventricle function basically recover, the probability of a positive acetylcholine test is about 30–40%. So the most likely area timing of a positive stress test, in my experience, is about 2 to 5 days. Only the patients that are destined to be a recurrent Takotsubo will have a positive acetylcholine test after a couple of weeks or so. Those are the ones that will behave like a pre-metal angina.
Can you remember? Okay. So it would be nice to be able to send you these studies and put them in the database. Is that web-based system up and running yet?
History of physical, but you need to send the movie for acquiring the imaging. And DICOM movies. This was the AVI. AVI are not adequate for a precise evaluation of the case. You need DICOM pictures. So you need to send them by mail. Even though there are systems that can allow you to do it by electronics, but at this time the IRB is, in our place at least, is having sort of allergic reaction to on the net transfer of medical material. Technically, it can be done, but they don't want to do it because of protection of identity and similar irrelevant problems. But I don't know. Probably in the future, we will allow us to go to a net-related transfer of records. But at this time, it would be better to put, I don't know, every month 2 or 3 CDs in an envelope and send it.
Paulo, do you see reperfusion injury when patients have Takotsubo or spasm?
Yeah, you can in terms of arrhythmias. After reperfusion from a cardiac massage, there are frequently recurrent ventricular tachycardia fibrillation for the first day or so. Once the situation is stabilized and there is no acidosis and no low cardiac output, that is not an issue, and there is no MRI provable damage. It's basically only a problem of transient arrhythmias, ventricular arrhythmias.
Yeah, and the animal models that we've worked with, like with pigs, with ligation of the coronary artery and then reopening the artery, 40% of the injury was reperfusion.
That's very clear, yeah. And I had the experience myself. We run some time ago a project in dogs that was preliminary to the introduction of an improved reperfusion. So we used in dogs balloon inflation to occlude, and then selective hemoperfusion with blood from the same dog from the kidney arteries, so oxygenated, and so that if you reperfuse slowly over 1 hour with the active perfusion through the balloon catheter, you have less death in dogs. Death reperfusion is fairly frequent. With this system, you could, we were adding carnitine for the reperfusion time. There were something like 90% reduction in the episode of ventricular fibrillation, but not much change in the ventricular function at the short term of 2 days.
Yeah, I'm surprised there's no reperfusion injury. I don't know how long you have to have the ligation, maybe 15 minutes or something before there's reperfusion injury. Maybe the spasm isn't that long.
Yeah, we were using the protocol that dogs had, I think it was 1 hour of total occlusion, and after 30 minutes we were starting the hemoperfusion, and eventually he was at 1 hour spontaneous reperfusion. We had to advance from that stage. There were several things that could have improved, and the project was aborted basically because the mortality was so high in dogs. But it is still obvious that the arrhythmias are quite important manifestation of reperfusion injury, but I'm not sure that we could establish that reperfusion anatomic injury is a real entity.
John, any further comments?
No, I think that very instructive, the issue of endothelial dysfunction after global ischemia just from a cardiac arrest versus the usual toxicity patient who doesn't arrest. But I think we just have to accumulate enough of these cases and see what the frequency is of spasm in response to acetylcholinesterase. So I will send you a flash drive or CDs or something of these two cases.
Very good. That will be very useful, and we'll get in touch about our impression after seeing real motion pictures. It would show much better.
Thank you, Paolo. I think we'll ask Dr. Morales to show a few cases next time. He's got some cases he'd like to talk to you about and wants to have greater understanding of how you treat patients with coronary artery anomalies.
Very good.
Thank you so much, Paolo. Thank you so much, John. Ciao.
Thank you very much, Eric. Bye.
Yeah, we'll post the video and give you the website where you can access it, and we'll give that to Jeff Schussler.
Wonderful.
Yeah, that'd be good.
Great, thanks. Bye.